Your last checkup came back clean. Cholesterol normal. Blood pressure fine. Doctor glanced at the numbers, nodded, said, "Looking good. See you next year." And you walked out feeling like you done your part. But I need you to hear something that your doctor likely never said in that room. I am a cardiothoracic surgeon with over 20 years of experience. I have operated on thousands of hearts, and I can tell you from inside an operating room, not from a textbook, that some of the most catastrophic arterial damage I have ever witnessed was sitting inside patients with completely normal cholesterol numbers. Completely normal. And here's the other side of that coin that almost nobody talks about. Some patients with what most cardiologists would call dangerously elevated LDL, their arteries were clean, healthy walls, minimal plaque. That should make you very uncomfortable, because if the number we've been chasing for 50 years isn't the real villain, then what is actually destroying your heart? That answer follows a chain of dominoes that most physicians never fully trace. And by the end of this video, you will understand your cardiovascular risk in a way that changes every conversation you have with the doctor from this point forward. There is one test, one number, that is more predictive of your heart attack risk than your LDL will ever be. Most of you have never had it checked. We'll get there. But first, let me tell you what I actually see. For the last 50 years, cardiovascular medicine built itself around one central premise. High LDL cholesterol deposits in artery walls, causes blockages, causes heart attacks. The fix, lower the cholesterol. The tool, statins. End of protocol. This model is not completely wrong, but it is profoundly incomplete, and that incompleteness is costing lives. I was trained in this model exactly like every other physician in my generation. Every attending I learned under pointed to the LDL number with the confidence of a judge reading a verdict. Then I started operating, and the picture inside patient's chest did not match the tidy story I had been taught. I have opened the chest of a man, 61 years old, whose LDL had been controlled on statins for 12 years, held beautifully around 70 milligrams per deciliter, textbook perfect, and found coronary arteries so severely narrowed with calcified plaque that the surgical challenge was significant. Decades of damage visible right in front of me, from a patient who, by his cholesterol numbers, should have been at low risk. And I have operated on patients with LDL above 200, patients whose cardiologist was alarmed and had prescribed statins they hadn't yet started, and found arterial walls that were notably healthier than I would expect for their age. I am not telling you to ignore your cholesterol. That would be irresponsible, and I won't do it. What I am telling you is that a number on a lab result is not a diagnosis. It is a fragment of a sentence. And if you stop reading after the first fragment, you will misunderstand the entire story. So, what is the full story? The answer begins with two biological processes that most standard 15-minute primary care appointments barely touch: chronic inflammation and insulin resistance. These are not buzzwords. These are the mechanisms I observe actively destroying arterial tissue every single week on my operating table. Here is what actually happens at the level of the artery wall. The endothelium, the inner lining of your blood vessels, is extraordinarily thin, one cell thick in places. A living, dynamic barrier that is fragile in a very specific way. When it is repeatedly exposed to blood sugar spikes, to elevated insulin, to oxidized fats, it becomes inflamed. It develops microscopic cracks. Damage accumulates invisibly over years. And here is the insight that I believe completely reframes the cholesterol conversation. LDL cholesterol does not initiate arterial damage. LDL responds to it. When the endothelium is damaged, LDL particles, which are primarily transport vehicles for fat-soluble nutrients, migrate into the vessel wall to assist in the repair process. They are part of the body's healing response. The plaque that builds up over decades is not cholesterol randomly depositing. It is a chronic repair process that never fully resolves because the damage never stops. The repair crew isn't the problem. The fire that keeps burning is the problem. And what keeps that fire burning? That is the first domino, and it leads somewhere that is going to challenge most of what you've been told. But before we get there, I need to share a case that changed the way I practice medicine. Because sometimes a patient teaches you more in 30 seconds than a journal article does in 30 pages. His name was Marcus. 53 years old, active, ran 3 to 4 miles 4 times a week. Conscientious about his diet in the way that anyone who follows mainstream health advice is conscientious. Low saturated fat, whole grains, the vegetable oils that had been marketed as heart-healthy for decades. He did exactly what he was told. His LDL was 114, completely unremarkable. He came to me for a triple bypass. When I opened him up, his coronary arteries told an entirely different story. Significant calcification, severe narrowing in multiple vessels, the kind of damage that takes years of sustained metabolic injury to produce. After surgery, I ordered a metabolic panel that goes beyond the standard lipid profile. His fasting insulin, a test that had never been ordered in 15 years of routine checkups, not once, was 41. Normal fasting insulin is under 10. His was more than 4 times that. His triglycerides were 267. His HDL, the so-called good cholesterol, was 33, critically low. Marcus was not a high cholesterol patient. Marcus was a patient with severe, progressive metabolic dysfunction that had been completely invisible inside a normal LDL number for 15 years. So, let me ask you something directly, and I want you to actually pause and think about this, not just let it pass. When did you last check your fasting insulin, not your blood glucose? Fasting insulin, the hormone that manages glucose, regulates fat storage, and drives chronic inflammation when it stays elevated for years. If you have never seen that number on a lab report, you are not alone. The vast majority of people watching this right now have never seen it because a standard lipid panel does not include it, because it is not part of the routine cardiovascular screening protocol that has dominated medicine for half a century. Which means the single most predictive metabolic marker for heart disease risk is being systematically excluded from the standard checklist. Here is the domino chain I need you to understand. The modern Western diet, high in refined carbohydrates, ultra-processed foods, industrial seed oils, produces chronic, repeated blood sugar spikes. Every spike demands an insulin response. Years of repeated excessive insulin demand lead to cells becoming insulin resistant. The pancreas compensates by producing more insulin. Chronically elevated insulin is pro-inflammatory. That inflammation attacks the endothelium. Damaged endothelium triggers the repair response involving LDL. Repeated repair, year after year, decade after decade, builds plaque. That is the chain. And for most people eating a standard Western diet, the first domino falls multiple times per day. So you thought the problem was the red meat. You thought the problem was the saturated fat. And for 50 years, that is what we told you. But the arteries I see in my operating room don't know what a ribeye looks like. They do know what 40 years of blood sugar dysregulation looks like. Now, and this matters, even if you've absorbed everything I just said and you're thinking, okay, I'll cut out the processed food, eat cleaner. That may not be enough on its own. Because by the time metabolic dysfunction is established, something has shifted that makes simple dietary willpower far harder than it should be. Insulin resistance, once established, is a self-reinforcing cycle. When your cells stop responding to insulin properly, glucose remains elevated in the bloodstream. The pancreas produces more insulin to compensate. More insulin means more fat storage, more inflammation, and paradoxically, more hunger and carbohydrate craving, because insulin resistance in the brain also disrupts satiety signaling. The system that should tell you to stop eating is broken. This is not a discipline problem. This is a biological feedback loop that the standard medical response, eat less, exercise more, here's a statin, fundamentally fails to address. And here is the conventional medicine approach that I find hardest to defend from what I have personally observed. The primary treatment for elevated cardiovascular risk in the current standard of care is statin therapy to lower LDL. Statins are effective at lowering LDL. I am not disputing the pharmacology, but here is what statins do not do. Statins do not lower fasting insulin. Statins do not significantly raise HDL. Statins do not reduce triglycerides in any meaningful way. Statins do not repair endothelial inflammation. Statins do not improve insulin sensitivity. They treat one downstream number while the metabolic fire continues to burn underneath. I have patients on 3 separate cardiovascular medications, LDL beautifully controlled, whose metabolic panels are catastrophic. When you look at the actual drivers of arterial disease, the disease is progressing. The number is managed. Now let me be very clear. If your physician has prescribed cardiovascular medications, do not stop taking them without a serious, thorough conversation with a doctor who specializes in metabolic medicine. That is non-negotiable. What I am advocating is expanding the conversation, not abandoning medical care. What we need is a different key for the lock. And this is where something unexpected enters the picture. Something that looks dangerous on the surface, that conventional cardiology is only beginning to grapple with, and the results are forcing a genuine rethinking of the narrative. There is a dietary approach that when I first encountered the metabolic panels of patients following it, I expected to see damage. These patients were eating red meat, fatty cuts, eggs, organ meats, animal fats, and nothing else. No grains, no sugar, no seed oils, no processed food of any kind. What's commonly called the carnivore diet. On paper, it looks like a cardiologist's worst nightmare. The labs told a completely different story. Patient after patient showed a consistent metabolic pattern, triglycerides falling dramatically, often from over 200 down to under 100, HDL climbing, sometimes from the low 30s to the high 50s or 60s, fasting insulin normalizing, A1C improving, blood pressure stabilizing, waist circumference decreasing. These are not the markers of someone developing heart disease. These are the markers of someone whose cardiovascular risk is measurably improving. Yes, LDL often rises, sometimes significantly, and I understand why that creates alarm given the 50 years of messaging we have absorbed. But here is the distinction that a standard lipid panel doesn't capture. LDL is not one thing. LDL particles come in 2 distinct patterns: small, dense LDL particles associated with high carbohydrate intake, elevated triglycerides, and elevated insulin are genuinely atherogenic. They're small enough to penetrate the endothelial wall and oxidize rapidly once inside. Large, buoyant LDL particles, the type that predominates in a fat-adapted low-carbohydrate metabolic environment, are significantly less atherogenic, too large to easily penetrate the arterial wall. The risk profile is fundamentally different. The standard LDL number tells you how many particles there are. It does not tell you which type, which means the single number your doctor circles on the lab report may be carrying far less information than either of you realize. Here are the metrics that actually matter, the picture I look at when I'm evaluating a patient's real cardiovascular risk. Fasting insulin is your most fundamental metabolic marker. Under 10 is reasonable. Under 5 is excellent. Above 15, and your metabolic machinery is already struggling, regardless of what your cholesterol says. Hemoglobin A1C reflects your average blood glucose over approximately 3 months. Under 5.5 is where you want to be. The range between 5.5 and 6 is often described as borderline, and frequently not acted upon in a standard checkup. I want to be direct. That range reflects years of blood sugar dysregulation that is already contributing to arterial damage. Triglyceride to HDL ratio. Divide your triglycerides by your HDL number. A ratio under 2 strongly suggests the large, buoyant LDL pattern, the less dangerous type. A ratio above 4 is strongly associated with the small, dense pattern. This single calculation gives you more actionable cardiovascular information than the LDL number alone. Waist to height ratio. Divide your waist circumference by your height using the same units. Above 0.5 indicates abdominal fat distribution that correlates strongly with insulin resistance, independent of your overall body weight. You can be at a normal body weight and carry this risk factor without knowing it. And the most powerful single test for directly assessing the state of your actual arteries, the coronary artery calcium score, a low-radiation CT scan that directly images calcified plaque in your coronary arteries. A score of 0 at age 55 means your arteries are, in measurable terms, biologically younger than your calendar age. A score of 350 means significant arterial disease is already present, disease that your cholesterol panel would never have detected. If you are a man over 45, this test is one of the most valuable things you can do for your long-term health. Full stop. And I want to hear from you. Leave a comment below telling me which of these tests you've actually had done. Fasting insulin, the CAC score, the A1C. I'm genuinely curious how many of you have had more than one of them checked, because what I hear from most patients is that nobody ordered any of them. Now here is the mistake that eliminates most of the metabolic benefit for people who try to shift their diet, the critical domino that undoes everything else. If you make the dietary transition gradually, if you reduce processed carbohydrates rather than remove them, if you keep the habits halfway in place, you may feel terrible for weeks and see minimal metabolic improvement. The fat adaptation process, where your cells shift their primary fuel source from glucose to fatty acids and ketones, requires roughly 3 to 6 weeks of consistently low insulin signaling to complete. Every significant insulin spike during that window resets the adaptation clock. The fatigue and carbohydrate cravings that many people experience when starting this approach are often the result of making the switch incompletely. The body is in transition, but never fully arrives. Make the change properly, or wait until you're ready to make it properly. Incomplete metabolic transitions produce incomplete results. Let me paint you the picture of what actually happens when the shift takes hold. In the first 2 weeks, most people notice something unexpected. The hunger patterns change. The mid-afternoon energy crash, the 3 o'clock dip that sends most people to the kitchen, begins to fade. This is not willpower. This is what stable insulin looks like from the inside. When blood glucose stops spiking and crashing, the hormonal signals that govern satiety actually function correctly. You eat when genuinely hungry. You stop when full. By week 3 to 4, the triglyceride shift becomes measurable. A 20 to 40% reduction in this time frame is common, and it is one of the most consistent findings across all low-carbohydrate dietary research. By week 6 to 8, many patients see blood pressure improvement, not because of reduced sodium, but because chronically elevated insulin causes the kidneys to retain sodium and fluid. When insulin normalizes, that fluid retention resolves on its own. By month 3, the A1C begins to reflect the new metabolic reality. And for some patients, the ones who stay consistent, fasting insulin reaches genuinely healthy territory for the first time in years, sometimes decades. What does this mean for arterial health over the long term? The fire that was causing the endothelial damage is no longer burning. The repair response, the one building plaque, is no longer being triggered with the same frequency. The arteries begin to stabilize. I want to come back to Marcus one final time. 2 years after his bypass surgery, He appeared in my office for a follow-up. He had found a physician who understood metabolic health, had radically changed his diet, had removed processed carbohydrates and industrial oils entirely, and had rebuilt his eating habits around animal proteins, fats, and whole foods. His fasting insulin, 6. His triglycerides, 88. His HDL, 57. His blood pressure, 119/71. No cardiac medications. He sat across from me and said, "Why didn't anyone check these things 15 years ago?" I didn't have a good answer. The honest answer is that we were taught to count the smoke, not locate the fire. And medicine moves slowly, even when the data is clear to those of us who look closely enough. My goal as a surgeon is not to fill operating rooms. My goal as a surgeon is to give you the understanding you need so that you never need to be in one of mine. Here is what I am asking you to do this week. Not someday, this week. Call your doctor's office and ask for fasting insulin to be added to your next blood panel. If they say it's not indicated, ask them to explain why. If they cannot give you a metabolically informed answer, find a physician who can. You are entitled to a doctor who looks at the whole picture, not just one number on a standard checklist. If what you've heard today has shifted how you think about your cardiovascular risk, about what cholesterol actually means, about what really drives arterial disease, about the gap between what's routine and what's predictive, share this video with someone you care about. That gap costs lives, and closing it starts with conversations like this one. I am putting together a follow-up video on exactly how to read a complete metabolic panel, what every marker means, what ranges to target, and how to have a productive conversation with your doctor about metabolic health. Subscribe so you don't miss it. The science on cholesterol and cardiovascular disease is being rewritten, not without resistance, and not as quickly as it should be, but the evidence is clear to those willing to look past 50 years of a single number. You deserve to know what I see from my side of the operating room.